Good evening, everyone. Welcome to First Aid AMC Clinical pre-review sessions today. Are everyone able to hear me clearly? Yes, very good. Perfect. So let's start our session today. So again, as I'm sure that all of you know about First Aid AMC, and that's why you are here. So tonight is mainly it's our one of the most awaited trial session that we normally take before our new course. And you might already know that our course runs twice in a year. So it is a very highly sought class. And in our trial session, we normally give you an idea that how we are going to take our class. And you might also be aware, because most of you are from our First Aid AMC MCQ course, that and also you're in our AMC Clinical Facebook group, that First Aid AMC Clinical has the highest number of passing candidate from clinical exam. So out of any course that you can join, this is the course where we have the highest number of passing candidates every month. So this is not something that we are doing for the first time. We have been helping the IMGs for the last 8 years. So throughout these 8 years, we have learned, we have also got experience to help you to pass this exam smoothly, more smartly, and in a very short period of time that you can prepare yourself for this kind of hard exam. Now, many of you might have some wrong idea. So tonight I will give you some good information so that you don't feel confused anymore and you get motivated. Because a lot of you have the idea that AMC Clinical is impossible to pass. And even if you pass AMC Clinical, you can't get job after AMC Clinical. Now, these are all nonsense, because even with part one, candidates getting job at the moment. So you should think that if you pass clinical, you should get job even faster than someone who is applying with just a part one. So I would not advise you to listen to others who demotivate you, and always try to get information from someone who is successful, someone who is already working in Australia, someone who can motivate you to push forward, because you are already in the journey and there is no going back. Because if you think that, well, no, I'm just exhausted, I want to go back and just continue doing what I'm doing, you just lost more than a year to prepare for AMC, MCQ, and everything else. And you lost your money as well. So there is no going back. So you have to think about going forward and being a doctor in Australia. And it is a dream for all of you, right? So getting into your dream is not the easiest thing always. You have to do your part, you have to do your hard work. And if you continue to do that, there is no problem. You will get job. But the guidance, the motivation, support, those are important. So my advice to everyone who goes through this journey is always just listen to someone who can support you in this journey, who can motivate you. Don't listen to others who is talking about, I have passed clinical, waiting for 2 years, even got a job offer. Something is wrong in that person. Maybe she or he doesn't have a recency. Maybe she has a long work gap. Something is there, and that's the reason why she is not getting job. And there is always a way to overcome those. Even someone having a long career gap, there are ways that you can go back and get a job. So it's not like you can't get a job. And if you ask me that what is the best way, the best way is always to pass AMC Clinical. Because when you apply for a job offer, and someone who is also applying, who just passed MCQ and you passed both MCQ and clinical, definitely you are going to be the person who is going to get the job. So that is where the AMC clinical exam is important. All right. So there are lots of other things in between that what we should do after AMC 1. We are going to take a full session on career guidelines, pathways, and all the registrations that you need in Australia. We take that class every time when we do these trial sessions before starting a course. So you guys are going to get one just in a couple of weeks. So we are planning for that class and we will post it in the Facebook group. Keep an eye and definitely join that session if you have any questions regarding your career and the guidance. Okay. So coming back to AMC Clinical, AMC Clinical is not the easiest exam that you are going to pass. It is hard, but trust me, when I see that every month there are, like, most of the times at least 7 to 10 students are passing every month just from our course. So it is not hard, because if it was hard, then they would not pass this exam. And most of the students who pass from our course, they are all first time attempt candidates. So most, about 80% are first time attempt. So it is a lot, definitely, because many candidates, they need to attempt like 5 6 times to get this clinical done. But when you join the course and when you listen to what we are saying and you follow the guideline, you will pass this exam if you just follow what we are saying, because the course has everything that someone needs to pass this exam. And we provide a portal full of research, full of notes and classes. So if you can finish all those things, there is nothing new that can appear in any exam. Okay? So, but you need to give time, you need to do the hard work. So nowadays, as you know, that AMC clinical exam is an online exam. And in online exam, it's not about just how you are doing each of the stations. It's also important that you sound clear, your video is clear, you have a good internet connection. So those technical logistics are also important to pass this exam. So many of you will forget about that because you just think that if you can finish the task, you're going to pass this exam. But online is a bit different. It is easy in a lot of ways because you don't need to get a visa to come to Australia and live here for a few days and then appear the exam, which is a lot of trouble. Nowadays, you can just appear the exam from your room, which is, trust me, it is a blessing to do that. But on the other hand, it is they have, because you are doing it in an online session, the criteria of passing this exam has got higher, the expectation has got higher. So previously, a little bit of, like, if you did some mistake, they would not be bothered with that. They were a little bit more easygoing. But with online exam, they are not that much easygoing anymore. On the top of that, they have reduced the amount of passing station to pass this exam. So you can understand that they want doctors to come in Australia. There is a huge scarcity of doctors, and they plan to bring more doctors in Australia. So this is a good time to pass your clinical exam and get a job offer. Even for the next couple of years, this will go on. So I would definitely say finish your clinical exam as soon as possible, get the job, because this is a high time to do that. Now, I'm going a little bit more and more into AMC Clinical, as you can see. I have kept you muted just to make sure everyone can listen to me clearly. And if you guys have any questions, you can always ask me in the chat box. If you have questions regarding career pathways, please keep it for our career guideline session so that we can discuss all of this together. But if any questions regarding AMC Clinical, feel free to ask me today, now or at the end of the class. And also at the end of the class, I'm going to discuss a little bit more about this new course that we are starting so that you know and you can ask questions if you have any. So we're talking about AMC Clinical is an online exam. And in online exam, they usually will give you they will give you an email where everything will be written, like what you need to do, what you shouldn't do. So everything will be written in that email and you need to go through this. They also ask you to download a software in your computer. And once you download that software and you open that software, in the exam time, you'll be able to go into a Zoom session. And your exam will be on that Zoom session on that software. Now, there is a lot of logistics that we normally discuss in our orientation class for the course student, like how, like there are information about what should be the size of your laptop, what you should use or what you shouldn't use. So those things we normally discuss in our orientation class in detail. Now, for AMC clinical exam, in an online scenario, it's very important that you have a very good connection. So make sure that you can also talk to someone over the Zoom session and make sure that your connection is not getting interrupted and you sound clearly. Make sure your camera is good. Now, many of your laptop camera might not have a very good resolution. So buy a good resolution webcam so that you look clear because that is important. Okay. And also dress professionally. I have seen people, like when we do the mock exams with you guys, I've seen people wearing just like a very casual outfit. You are going for an exam to become a doctor in Australia, so casual dressing is not preferred in this scenario. So dress professionally and make sure that you sit straight and make sure that your video shows your face and a little bit part of your maybe upper part of your chest, but mainly your face should be visible. And always look, like, because you can see what's visible on your camera. Always look that how, if you sit in a specific way, how you look like. Because if most of the screen is not you, but most of the screen is showing the surrounding part of your home, that is not good. So make sure you come a bit closer to the laptop so that your face is clearly visible. And also they advise you to wear a microphone during the exam, no Bluetooth or anything. And have a contrast, like we normally advise that if you're wearing something black, your wall should be a bit of whitish. So the contrast actually makes it bit better. So, and also looks professional, that you have a contrast between your background and what you are wearing. So these kind of things are very tiny little things, but it makes a difference. Okay. Also, we advise that make sure that the room is clean. Make sure there is no noise coming from outside. That is very important because most of you will have your babies screaming at your door. Please make sure that you have just for that day, make sure that you have a noise-free like room at least. Okay. You should not keep any watch on your room because having a watch is prohibited. And you can't also keep any table watch or computer watch visible during your exam. We also advise that sometimes there are few other things that they prohibit. So please make sure you don't do that. So we will discuss in detail about that. Now in AMC clinical exam, there will be a couple of people. So you will be there. Then there will be a invigilator. The invigilator is someone who mainly conduct your exam. So let's say that this is you in the Zoom. Then in here you have got the invigilator, and there will be a role player in your session, and then there will be an examiner. So there will be these 4 people in a room for each of the stations. Now, as coming to the stations, you will be giving 16 stations in the exam. So you get 16 station plus 4 resting station. So these are 20 stations that you will be rotating. Okay. Each of the stations is of 10 minutes. Out of this 10 minute, 2 minute will be your reading time. So on this screen, you will be seeing a question with your task, like what you need to do. So your task might be 1, taking a history, 2nd, do a physical exam, 3rd, giving a diagnosis and further management. So they give you a question and the task, and within this 2 minute reading time, you will be able to read it and you will be able to think what you're going to do in this case. Unfortunately, you can't write anything during the initial 2 minute time. So you can keep a paper and a pen in front of you to write. But only time you can write is after this 2 minute is finished. So once 2 minute is finished, you will get a prompt from the invigilator to start the case, and you will get 8 minutes to finish all the task that has been given to you. So this will be your one station. So 2 minutes plus 8 minutes, 10 minutes. After 10 minutes, your exam in that room will be over and you will be rotated to the next room. And this thing will be rotating for everyone. After each 4 station, so after each 4 station, you will go into a resting station. Okay? In the resting station, you can sometimes they allow you to take a snack. They also allow you to go to washroom if you want. Okay? So this is the stations. Now, out of these 16 stations or 16 Ks that you will get in the exam, 2 of these cages will be pilot cages or non-scored cages, but you will not know which one is pilot case. So each of the stations are equally important. Okay. Now, out of these, so 2 cages are pilot, so you have got 14 scored stations. So out of these 14 scored stations, if you pass 9 out of 14, you pass the exam. Okay, it's not very difficult because you can fail 5 stations, right? So it is okay to miss something. So many people, many doctors or candidates, they get very, very like scared after like if their one station goes wrong. Now you can see that you can make 5 station completely like haphazard. You can do it completely wrong. Still, you can pass this exam. Okay, so if you understand this, then you will get more motivated during your exam. That yes, I got this station wrong. I still have a lot of stations I can pass. So it is totally okay. So no, Dr. Vinita, you are not allowed to write in the initial 2 minute, but in the 8 minute time, you can write anything you like. Okay, but 2 minute you can't write. All right. So now we know that you need 9 stations out of 14 to pass this exam. So how all these stations are marked? That's also important to know. So each stations will have different criteria and different tasks. So as I said that, let's say your case 1 will have 1, 2, 3 tasks. So let's say a patient coming to you feeling very sad and lonely because he has lost his partner recently. Okay, that's your question. Your task will be to taking a history from the patient, and then also they can say that give diagnosis and differential diagnosis and talk about further management. So these are your tasks. So when they mark you in the exam, marking will be from 0 to 7 for all of these tasks. Out of 0 to 7, you need at least 4 total to pass a station. How so? So in the history, they will give you, let's say that you got 4. In diagnosis DD, you got 4. In management, you got, let's say, 5. And they also give you another scoring for your approach to a patient. So approach is very important. For most of the cases, you get some mark for the approach. So many of you don't feel like you need a good approach to pass this exam, but approach is really important. So how kind, empathic you are makes one task in the exam. And our students always get highest mark in approach because we made them to have a good approach. So let's say in the approach you got 5. Then out of all of this, they give you a global score based on these marks that you have got. And global score, if you do an average, you will get 4 anyway. Okay, 4.5. So if you get global 4 in a single case, that case is passed. Now, it is not always very straightforward like this. Sometimes there will be key steps in every case that you should not miss. If you miss a lot of key steps, even if you have done history, diagnosis, management right, globally they can fail you. Saying everything you did right, you finished everything, but your approach was very bad. So you got 3 or 2 in the approach. Even though if they do average, you might pass this case, still they can fail you because your approach was not right. And after each station, examiner asks the role player that how did you feel about this candidate? How was the approach? If the role player says, no, I don't like this candidate, whatever you did doesn't matter, you will fail that case. So that is why we always advise that having a good approach to the role player is must. You can't just think that you will pass the exam if you just finish your task in the given time. Okay? Does it make sense, guys? Yes, Dr. Saba, you are allowed to look at the initial information in the 8-minute time. So the screen will show the question for the rest of the 8 minutes. So you'll be seeing that. Next year, also conducting through online. No one actually knows the answer to that yet because AMC hasn't said anything really about the next year exam. So we will see. But as this year was all online exam, it is most likely the next year will be online fully as well. Okay. Now, guys, we are moving on to our trial sessions today, so which is our psychiatry, psychosocial history. Now, for AMC clinical preparation, just like your MCQ exam, you need to be preparing for medicine-related cases. You need to prepare for gynae and obstetrics. You need to prepare for psychiatry, pediatrics. These are your main subjects that you need to go through. All right. And there are questions which always comes in exam, and that will be covered in the course anyway. And course is designed in a way that you are aware of the important questions in the exam, the important topics that is coming in the exam. So you will be very much well orientated with the exam scenarios and all. Now the classes are divided into theory-based session and role-play based session. So I'm going to take all the theory-based classes, and I'm going to form your main basic about the clinical exam. And there will be few other mentors who is going to take the role play classes. So you'll be doing role play of the cases that is important for the exam, and also some of the cases that I am doing the theory for you. And also I do the role play after we finish few topics. Like if we finish cardiology, I will do role play on cardiology topics with you. So there will be a lots of role play anyway, and you will get enough time and enough way to do role play with us. Now, many of you who are beginner are hearing few things for the first time, like role play. So throughout your AMC clinical preparation, role play will be the most important thing. The role play means that you give a case to your study partner and you just allow her to do that case. And we'll be doing a role play class in the free 2-week session, which is starting from 11th of August. Okay? So tonight's session is a theory-based class, not a role play-based class. Next class that I am taking on 11th August, which is our first class of free 2-week session, that will be a role play session, and you will know what role play means on that class. Okay, moving on. So psychiatry is a very important subject for AMC Clinical. It mainly forms your basics. It gives you an idea that how your approach should be. And psychiatry cases are complicated. It is an adventure sometimes in the exam to pass the psychiatry cases. That's why we normally take 4 sessions on psychiatry to give you a very good knowledge on it. Tonight's session will be the basic, or it's the main base of your psychiatry learning. And the base is history. How you can take a psychosocial history in a psychiatry case. It's a very, very important thing. And most of you will get mental status examination in your clinical exam. It's kind of a paid question that everyone, like most of you, will get a MSc or mental status examination. And tonight class mainly will form that. So psychosocial history, let's say you have got a patient who is very sad and feeling hopeless, feeling guilty. So by looking at the question, you know that this patient might be having a depression. So your task would be in such cases that you have got a 26-year-old patient who is very sad, lack of sleeping, having suicidal thoughts for the last few weeks. Your task would be to take a history from the patient and then present mental status examination finding to the examiner. So first task is taking a history from the patient and then presenting the mental status examination finding to the examiner. Now remember, in online exam, you can talk to the invigilator, you can talk to the role player, but you can't talk to the examiner. So examiner will be there online. You will not be able to see the face of the examiner, and they will never answer you back. So make sure that you don't bother with the examiner. They are not going to talk to you. But you can talk to them if there is a task, but they are not going to talk back. Okay, so moving on to psychiatric history. So first of all, how we start a psychiatric case. So there is 2 ways to start a case. One is a conventional approach, which everyone follows. And first thing that comes out from your mouth, examiner will know that, well, this candidate just memorized a note. And that is not a good thing. You will be filtered in your clinical exam. Out of all the students who is appearing in that day, they will only take maybe 3 or 4 will pass in that exam. Okay, so it is not the easiest exam, as I always say, but Getting filtered out of those candidates, it's easy if you follow what we are saying, because you can't just follow things that is written in a specific note or in a specific book. You have to be a little bit creative. The conventional approach, which many students will follow, is like, "Hi, John, this is Dr. Arshan. Let me assure you," or they will say, "I can understand from the note that you are sad. I'm going to ask you a few questions. Let me assure you, whatever we talk today will be between you and me, unless it is harmful to you or others." Now, this is a very casual way of starting a psychiatric case. But I don't like this approach because it will be done by most of the candidate. I want you to follow something creative, something more empathic, something which will make you different from others. How so? So you can start in this way. Now listen that how we change our way of talking matters a lot in the exam. You can't just say that I am very sorry to hear that you are sad and you are not sounding sad. You have to sound sad as well. The problem with the first time candidate is that they don't think that this is a real exam scenario. They just think it is an exam scenario. These patients are simulated patients. I don't care about their feelings. But the cages are designed in a way, and you are actually getting tested on that purpose. That do you actually feel this patient? Do you actually think, or do you actually being empathic with this patient? And that matters a lot in the exam. Are you going to pass or not? But first time candidate, they forget about these important things. They just want to finish the case in time. So you will start in this way. "Hi, John. I'm Dr. Ashan, one of the doctor in this clinic. It's very nice to meet you. John, I can see you that you are really sad. I'm so sorry for that. I want you to know that I'm here to help you, and you can tell me what's making you really upset. John, sometimes things doesn't go what we plan. Sometimes life really gives us difficult times, but with enough support, with with enough care, you will be better. It will not be the same always. I'm here to know what's going on with you so that I can help you. I want you to understand that whatever you are going to discuss with me today, it is confidential unless it is harmful to you or others. John, would you tell me a little bit more about what's making you sad? Now, tell me which one is better. You don't need to even tell, right? Because how you did the first one and how I have done the second one, there is a huge difference. And when an examiner listens to the second one, immediately they will know that, yes, this candidate is different. This candidate is empathic. And that's where you will be on a very higher tier than the others. Okay? So follow this alternative approach in most of the cases where reassurance and being empathic matters. So once you have done your initial approach, most of the patient will open up with you. So psychiatry is challenging in a sense that if you don't give the confidentiality statement, they are permitted not to give you any answer in the exam. So if you don't give the confidentiality statement in a psychiatric case, you can fail that case straight away. And the role player, they are permitted not to give you correct answer in that time. So they can just like loop, like you will be just running in a loop and you will not come into any kind of diagnosis because role player just messing with you because you haven't given confidentiality. So confidentiality is the number one key step for any psychiatric case. Once you have done that, patient will give you something that, doc, I'm I'm just feeling very bad because I just lost my partner recently, or I have a breakup with my girlfriend recently. So then what you would say? So We always start with the open-ended questions for the patient to give us any information that they have. After we get the information, then we move on to some direct questions. So we ask the patient, I'm so sorry to know that, John, it must be very hard. So how long this is going on? How long you're feeling this way? So always get the duration from the patient because your diagnosis depends on the duration sometimes. So once you have got an idea about the duration, then you ask, then the next thing is you're going into the psychosocial history. So then you ask, so John, how's your mood these days? So our first question is to ask about the patient's mood. Okay, so patient says, I feel very sad and lonely. We also ask the patient sometimes that, is there any time that you might be feeling very high? So, because if the patient is feeling sad, the patient might have depression. We always rule out bipolar disorder in a patient who can be depressed. So, when the patient says low mood, we ask the patient that, is there any time that you can feel very high at some point? No, doctor. Then we ask about their sleep and appetite. So, how's your sleep and appetite? Now, every time we get something positive from the patient, we ask a little bit more. Like someone having sleeping problem, we would be asking that, so how long you are having the sleeping problem? Do you have difficulty to fall asleep? Or do you wake up early in the morning? Do you get nightmares or broken sleep at night? So all of this question has some meaning. If a patient has sleeping difficulty initially, that means they're having difficulty to fall asleep, that suggests anxiety. If a patient waking up in the early morning and can't go back to sleep, that suggests depression. If a patient getting multiple broken sleep and nightmare, it can be a presentation of post-traumatic stress disorder. Okay, so only time we ask the questions if we get something positive. So we got mood, sleep, and appetite. After that, we ask about the suicidal risk. Every psychiatric case, we will assess if a patient has suicidal thoughts. So you ask the patient, do you think your life is worth living? If a patient say yes, then you don't ask any of the other questions. But if a patient say no, you would ask, do you have any passing thoughts of harming yourself or others? Any definitive plan to commit suicide? Any access to weapons? Any previous attempt? So these questions are only asked when you get positive finding from the patient that, yes, doctor, I don't feel my life is worth living anymore. So then you will be asking, do you have any passing thoughts of harming yourself or others? Patients say yes. So do you have a definitive plan? Do you have any access to weapon? Have you ever done any such attempt? So get a good idea about the suicide. Now, depending on our task, we always change our format. Now, remember that our clinical course is designed in a way so that you can just have a format in your head and you can use that same format to finish multiple cases. So that's called cluster-wise approach that we provide in our course. In a cluster-wise approach, you learn the history format, and using the same format, you'll be able to do 10 cases. So for 10 cases, you don't need to learn any new history. Only thing you would need to know is how you're going to manage that case. So that's the smartest way to finish a lot of case because you will have more than 300 cases to learn. And you can't just like memorize all these cases. So those cases will be clustered into a single format. And in a way, it becomes so easy in the exam to finish. And your preparation will be very smart and concise. So why we are talking about the format? Because this is your psychiatry format. And using this psychiatry format, every history that you are going to take will be under this format. So for psychiatry, there is no other history. This is the history. And using this same history, sometimes we will be adding a little bit more. Sometimes we will be like removing something from the format, but the format will be like this. Okay. Now, let's say your task was to give a diagnosis also. So when the task adds diagnosis and differential diagnosis, then your history will be a little bit more detailed. If the task is only taking a history and giving a mental status exam finding, the history will be a little bit less. So if, let's say, there was a task of giving diagnosis and differential, a patient who is sad, having sleeping problem, your main diagnosis is depression. So in that case, you will be asking depression related question. Okay. So for depression, now tonight we are not going to discuss this case by case thing, but I will just give you an idea. So there is M-Psych caps. I hope you remember from MCQ. So M-Psych caps gives us the diagnosis of depression, right? So M for mood, which you have asked. S for sleep, which you asked. I for loss of interest. So in this case, you will be asking that, do you still enjoy things that you used to enjoy before? Now, all of this will be discussed later on. So don't worry, you don't need to write anything. So have you lost interest in things that you used to enjoy before? G for guilty. Do you feel guilty about anything? E for energy. So do you feel tired and fatigued all the time? C for concentration. So any lack of concentration or attention. A for appetite, which you have asked. P for psychomotor retardation or agitation. So do you think you have slowed down recently? And S for suicide, which you have asked. So this is M-Psych caps. Only times you will add it here if your task says to give diagnosis and DD. And based on the presentation, these questions will be different. Like if your question is patient is having manic symptoms, then you will be asking mania-related questions. So it is going to be different case by case. But for this particular case, where patient is sad, we have to rule out depression. So we'll be asking questions that hasn't been asked. Okay? So once you have asked those questions, you will say, now I'm going to ask you some screening questions that may seem quite strange, but these are screening questions and I ask these questions to everyone. So please bear with me. So now we are asking questions to rule out schizophrenia or psychotic condition. So hallucination and delusion. So for hallucination, we ask, do you see, feel, or hear things that others don't? So seeing means visual hallucination, feeling is tactile hallucination, and hearing is auditory hallucination. In mental status examination, hallucination is part of perception question. I'll come to that later on. Then after hallucination, we ask delusion question. So for delusion, we have a mnemonic called RCGGP. So what is RCGGP? R for delusion of reference, C for delusion of control, then G for guilt or delusion of guilt, G for delusion of grandiosity, and P for delusion of persecution. So persecutory delusion or paranoid delusion, they are same. So for delusion, these are the 5 questions that's important to ask. So for persecutory delusion or paranoid delusion, do you think someone is spying on you or trying to harm you? Do you think someone is controlling you? Do you think people are always talking about you? That's delusion of reference. Do you think you are guilty? Do you think you have some special power? That's delusion of grandiosity or delusion of grandeur. So these are the 5 questions that's very important to ask if you suspect patient having schizophrenia or psychotic features. Now, there is not the finishing of delusion question. We also ask thought insertion, thought withdrawal, and thought broadcasting. So we ask, do you think someone is inserting or withdrawing thoughts from your mind? Do you think your thoughts are being broadcasted in TV, radio, or newspaper? So these are all under delusion. So you have got RCGGP followed by delusion of thought insertion, thought withdrawal, and thought broadcasting. Okay? So you have done hallucination and delusion. Then we have 3 questions: insight, judgment, and cognition. Now, there is also a mnemonic to remember all of this. That is our AMC format where we do the aseptic J3R. Now, in the aseptic J3R, we have got insight, cognition, and judgment. So ICJ. So that's the 3 questions we are asking at the moment. We will come to that just in a moment. So now you are asking insight. So for insight, we ask, do you think you need some medical help or any professional help? Patient who lacks insight, they will say, no, I don't need anything. For judgment, we ask, if there is a fire in this room, what will you do? Someone who is having active psychiatric issue, they would say, I don't care, I will just stand here. Some might say, nothing, I will just stay here because fire cannot touch me because I am a messenger of God. So they will say different thing. And someone who has a good judgment, they will say, I will just run. Okay, so we are taking the insight, judgment, and then cognition. For cognition, we try to find out if a patient is oriented to time, place, and person. So for time, do you know what is the date today? For place, do you know where are you? And for person, do you know who I am? So these are the 3 questions to find out if a patient having good cognition or if the patient is well oriented to time, place, and person. So this is your aseptic J3R that we normally do. Now, after you have done this, every psychiatric history will be finished with this format: heads, SADMA, past medical history, ruling out organic history, and family history. So what is heads? Heads is a very important thing for psychiatric questions. So heads is a mnemonic for home situation. So in MSc format, there is no heads. Okay, we'll come to that. But in other psychosocial history, heads is important. So heads 1 is home situation. Then E for education or employment. A for activity. D for drugs. S for social support. And sometimes another is for sexual intercourse, but we also keep it as a stress. But we don't need to do any of this. So we normally only ask from the heads is home situation, work situation, and support and any stress. So the question you will be asking, who do you live with at home? How is your home situation? Is there any stress? Do you work or study? Is there any stress at your work? Do you have enough support? Okay, so it's mainly asking about the home and work situation and if there is any stress there. Then we ask about the SADMA. So SADMA is also another psychiatric questions, and also in in medicine and almost all the history, we ask SADMA. SADMA is about smoking, alcohol, any recreational drugs, any medication, any allergies. So from SADMA, we only ask, do you smoke or drink alcohol? Any other recreational drugs? Do you take any regular medication, any known allergies? Any past medical history or any past history of any mental illness? Any family history of any mental illness? It's also important to rule out any organic cause because there are some organic cause which can mimic psychiatric presentation, especially thyroid condition or head injury. So have you noticed any change in the weather preference and any head injury recently? Flu-like illness is not really important, so don't bother with that, but mainly focus on weather preference or head injury. Weather preference is someone who has thyroid problem, like someone who has hypothyroidism. They always feel cold, even in the hottest weather. So someone who has hypothyroid, they will say that I always feel cold and I can't tolerate cold weather. Okay, so that's ruling out organic causes, and that's the finishing of your history. So history is quite long, right? So it's not always that we ask all of these questions. Sometimes based on the history, we remove things to make it easier for us and to make it finishable in the exam. But this is the format. So coming back to give you a summary of what we have discussed so far. So if your task is to take a psychosocial history, you will start with greeting and introduction with the patient, confidentiality statement, and then you start with mood, sleep, appetite, suicidal risk. Then you ask questions if there is like diagnosis in the task, then you add more question. Then you ask hallucination, delusion, insight, judgment, cognition, heads, SADMA, past medical history, family history, organic history. So you are going to only remember that, nothing else, because you will be very comfortable with just remembering these main things. So if you just close your eyes and think that this is what I'm going to do in this case, so I'm going to greet with the patient, give a confidentiality, then ask about mood, sleep, appetite, suicidal risk, talking about hallucination, delusion, insight, cognition, judgment. Then I'm finishing with heads, past medical, family history, SADMA, organic history. That's it. Okay. Now I know that it's not very easy initially, but once you start preparing for it, it is going to become better. And it is easy. So your first task is done. You'll thank the patient and then you'll explain what you have found to your examiner. And that is called MSc presentation. All right. So MSc presentation means that you have taken a history from the patient and there are some findings that you have got. And those findings you can write in the paper. So what we advised everyone that when you first start this case, after the 2-minute time, just write aseptic J3R like this on your paper. So that any finding you get, you can just write very quickly that what you have found. Okay? Because you would forget about the finding when you are giving this MSc to the examiner. So what is this aseptic J3R? Aseptic A for appearance and behavior. So what is the appearance of the patient and what is the behavior? Then speech. How was the speech of the patient? Was it normal? Was it pressured? Was it disorganized? E for emotion. We talk about mood and affect of the patient. We will come into that. Then P for perception, where you talk about the hallucination. Then you have got thought form and thought content. We will talk about what do we mean by thought form. Thought content is the delusion part. Then ICJ, insight, cognition, judgment. So you have got aseptic J3, and then there is 3R. So you finish with 3R, which is risk, repo, and reliability. All right. So this is the main format based on which you are going to present your MSc to the examiner. So are you guys with me so far? I know I'm talking a lot, but if you are not understanding at any time, just ask. Are you with me so far? You're understanding? It's not getting boring? Psychiatry is a boring topic. Making it fun and helpful is difficult. So I'm hopeful that you are not getting bored. This class will be in recording, Dr. Nida, that's right. Not bored, little scared. That is how you should be, right? But it is going to get better, trust me. Perfect. Moving on. So in the MSc format, so once you finish your history, you will say, thank you, John, for all the information that you have given. Now I'm going to talk to my examiner and come back to you. So your starting will be like that. Dear examiner, I'm going to present the mental status examination of my patient, let's say John, a 35 years old doctor found by his partner trying to hang himself in the garage. So it depends whatever your patient is. So they will give you a 35-year-old John who has been found by his partner trying to hang himself in the garage. So you always give a brief introduction of the patient before you present the MSc. Then you start with appearance and behavior. So in the appearance and behavior, you mainly focus on this point. So how is the dress? Is he dressed appropriate to the weather? Is he well groomed or unkempt? Is he cooperative? Is he maintaining eye contact? Because depressed patient will not maintain eye contact. Abnormal body movement or posture. So usually depressed patient, they have a stooped posture. Anxious patient, they have this frequent fidgeting. Mania patient will be restless, agitated. And sometimes schizophrenia patient can be distracted. And sometimes they can be responding to unseen stimuli. What does it mean? It means that sometimes you will see that when you are talking to a schizophrenia patient and they might look at the ceiling or different part of your room as if they are seeing someone or as if they are listening voices of someone. So when they show you that in the exam, you just need to say that patient seems to be distracted and responding to some unseen stimuli. So they give this kind of case in the exam. Okay. So in terms of appearance and behavior, you will be talking about this. Then you come to the speech. So in the speech, one, that patient's speech can be normal in rate, volume, and tone, or patient can be slow and monotonous, or patient can have rapid pressured speech. So normal, you understand a normal speech, but slow monotonous is something that we find in depression patient. So they will be very slow and they will just talk by word by word. Like if you ask the patient, what actually happened? So patient will say, I'm so sorry. I just I just killed my patient. So something like that. Now you will be very angry in the exam, not in the real life, that why you are not fast because I'm running out of time. but you can't show your anger in the exam. You have to be very empathic. You have to be very, very like very calm in that situation. They know that this patient is supposed to be slow, and that's fine. But you can't just rush the patient that no, you have to talk faster. I'm running out of time. You can't say something like that. Okay. I've seen patients like I've seen candidates doing that. So slow and sorry. So slow and monotonous speech can be found in depression. Rapid pressured speech is a finding that we get in mania. So rapid pressured speech is someone talking loudly and not taking any break in between, and looks like they're just like putting pressure in every sentence that they're talking. So rapid pressured speech is a finding for mania. Patient who has depression, they also can take pauses in between each sentence they say. Mania patient can be like they don't answer your questions, they just talk and talk and talk. And sometimes you can get disorganized speech in psychiatry, like a schizophrenia patient. But in exam, they don't give you disorganized speech because in that way, you will not find anything positive. So they usually don't give that. But in real life, you can get quite a disorganized speech in an actively psychotic patient. So speech mainly talk about if the patient's speech is normal in tone, volume, or rate, and if it is slow or monotonous, if it is rapid pressured. Next is E. E for emotion. Emotion has two parts, mood and affect. So mood is what patient says when you ask, how is your mood these days? So patients say, I feel very sad and lonely. So according to the patient, his mood is low and lonely. So whatever patient says, you would need to say that here. But the affect is what you have observed in the patient. Did you also observe that patient looks very sad? If it is yes, then you will say the affect that I have observed is congruent with his mood. All right? But psychiatric patient, like actively psychotic patient, if you ask that, how's your mood? Patients say, yeah, I'm fine. But you would see that they're quite disturbed, right? So in that case, you would say, according to the patient, his mood is fine, but the affect I have observed is not congruent with his mood because he seems quite disturbed. All right. So there is the emotion, which will include mood and affect. Next, perception. In terms of perception, we mainly talk about the hallucination. So we have got auditory, visual, and tactile hallucination. So I will show you at the end that how we normally say everything. So we have done appearance, behavior, done speech, emotion, and perception. Next is thought form. So thought form, the normal thought form is linear thought form. So linear means that if you ask a questions to the patient and patient is answering that questions appropriately and you are understanding them, that means patient having a linear thought form. And most of the exam questions, the thought form will be linear. But there are lots of abnormal thought form that you can find in a real life. Like in a schizophrenia patient, you can get loosening of association, and the subtype of loosening of association is tangentiality and circumstantiality. What does it mean? So tangentiality means that you have asked a question to the patient. It's like, what's your plan today? Patient says that, well, I live in Queensland, but the sun is not very bright today. Oh, I was supposed to go to the movie with my mom. No, my brother is coming tomorrow. Oh, that fish looks very good. I have to eat that fish. So you can see that there is every sentence patient is saying there is no congruency. That means patient is just talking rubbish and he's not answering your question. Now, when that happens, that is tangentiality. Okay, so means that you're not getting your answer and patient is just deviating from the question on and on. On the other hand, the circumstantiality is kind of a circle. So you ask a question, patient will go like a circle, and at the end, he will answer your question. Like, what's your plan for today? Oh, the Queensland is very hot this summer. No, the Melbourne is good. Maybe I'm going to have. I just need to read that book. Oh, I'm supposed to go for shopping today. So patient has answered your question at the end, but initially he just said nonsense. He didn't answer what you talked. So that's called circumstantiality. Like patient talk and talk initially like out of the question, but at the end answer your question. So that's sometimes we find in schizophrenia patient. Sometimes they can also have a concrete thinking where they don't understand proverb or they just respond to the question literally. Like, how do you feel? Patients say, I feel with my fingers and toes. So this kind of answer also known as concrete thinking. On the other hand, you can get flight of ideas in a mania patient. Now, you can get quite confused with loosening of association with flight of ideas. So, loosening of association means there is no connection between each sentence patient says. Every sentence is different and not interconnected. Whereas flight of idea, they have a small amount of connection in between each sentence they say. Like, what's your plan today? So patients say, oh, I was just going to have my brother. My brother is very lonely. He is lonely, but both of us really enjoy a lot. And we are supposed to go and watch a movie today. Now, see that like there is jumping of from one sentence to another. There is no connection, but still they are making a small connection in between. That's called flight of ideas. If I give you a little bit more example of flight of ideas, I loved that movie. I'm going to watch a movie with my mom. My mom adores me. Every sentence has a connection, right? But there is a rapid shift in the conversation topic. Initially, it was movie, then watch movie with mom, and then my mom adores me. So there is a connection, but they are just jumping from one topic to another topic. Same in here. My father sent me here. He dropped me in a car. The car is yellow in color. Yellow color looks good on me. So are you guys understanding what is the difference? Like, what is the main thing of flight of ideas? Whereas if you see the loosening of association, I went to the market. Oh, I should read that book. When did you buy this dress? It's a lovely evening. I should go for a walk. I feel like having a chocolate. I need to study for the examination. That movie has very good reviews. If you see here, there is no connection of anything. So that's called loosening of association. Okay. So now we know what is the thought form. The normal thought form is linear. Then we can also have loosening of association, tangentiality, circumstantiality, concrete thinking, and flight of ideas. Next, thought content. So thought content you already know. So delusion will come into the thought content. Sometimes we also include eating disorder, body dysmorphic disorder, which is overvalued ideas, and obsessional thoughts in OCD under thought content. So this obsessional thought, delusion, and overvalued ideas in eating disorder or BDD will be included in thought content. After thought content, so we have done all the T. Then we have I, C, J, and 3R. So I for insight, then cognition, and then judgment. and then 3R. In the 3R, we have risk of the patient. Now, there is a very important thing. Every mental status examination should include how risky this patient is. So if a patient has active suicidal or homicidal thought, if a patient has got active hallucination delusion, that patient is high risk. Okay? So active hallucination delusion, active suicidal homicidal thought, that patient is high risk, except that the other patients will be low to moderate risk. Rapport. So rapport means that were you able to maintain a good relation with the patient during this conversation? Now, if you are not able to maintain a good relation because patient was very cranky and shouting or screaming at you, that's not your fault. The case was supposed to be like that. So whatever happened, you can say. So if the patient was very good with you, he or she was answering your questions appropriately, then you will say, I was able to maintain a good rapport with my patient. If patient was being very cranky and screaming and shouting, you would say patient was not maintaining a good rapport with me. Okay. And the last thing is reliability. The history given by the patient, do you think it is a reliable history or not? If it is not a reliable history, you need to take a collateral history from someone who knows this patient, family member, friends, neighbor, relatives, anyone who knows this patient, you need to take a collateral history from them. And always remember that someone who has loss of insight, someone who is having active psychotic condition, they don't give a reliable history. And you need to take a collateral history. That means schizophrenia patient, most of the time, mania patient, most of the time, will need a collateral history from a family member. Okay? And that's your finishing of mental status examination. And you'll thank the examiner and finish the case. Remember, unless the task says give diagnosis, you don't need to give a diagnosis in MSc presentation. Does it make sense for everyone so far? So the classes are mainly 2 hours duration, Dr. Bond. All right. Now, I'm going to discuss that how you are going to do a case. Like means how you are supposed to present MSc in the exam. Okay. So let's say your patient is depressed, having suicidal thought. What would you say? So you'll say, Dear examiner, I would like to present a mental status examination of my patient John, who is a 35 years old patient found by his partner trying to hang himself in the garage. In terms of his appearance and behavior, he is well dressed. He was well groomed and cooperative, but he was not maintaining eye contact. He was sitting in a stooped posture, but he was not having any fidgeting or restlessness. So you give positive and negative both. His speech was slow and monotonous, but there was no rapid pressured speech or any disorganized speech. According to the patient, his mood is low, and the affect that I have observed is congruent with his mood. He did not have any auditory, visual, or tactile hallucination. His thought form was linear. There was no loosening of association or flight of ideas. As part of his thought content, he did not have any delusion. He was oriented to time, place, and person, but he did not have any insight because he thinks he doesn't need any medical help. His judgment was impaired because he said that he's just going to stay in the room if there is a fire there. He is a high-risk patient because of active suicidal thought, but I was able to maintain a good rapport with my patient. The history that was given was not fully reliable, so I was I would like to request a collateral history from his family member, please. Thank you, examiner. Okay, so that will be your mental status examination presentation. Okay, does it, is it clear for everyone, like how you are supposed to do it? So that means if you don't write the findings in your paper, sometimes you can miss important things. So I always advise just write it in your paper. What are the findings you have got in the appearance? How is the speech, emotion? Just very quickly, when you are talking to the patient, write. And that will make it very smooth in the exam. Can you repeat the thought content? So thought content is delusion. So if you see the delusion one, so thought content mainly talk about the delusion. If the patient has any delusion, say that as part of his thought content, he had delusion of guilt, delusion of persecution, and delusion of control, but he did not have any thought insertion, thought withdrawal, or any thought broadcasting. So it depends what you find. And if you're running out of time, you will make it smaller and shorter. Ideally, Dr. Arthi, yes, I advise that if you can make it a bit of positive and negative both, but time is the essence, which means that if you think that you might be running out of time, then you will just can give a positive finding because that's the main mark. So it always depends on your time and how easy was the case. But if you think you're running out, just say the positive findings one by one. All right, guys. So that's mainly about the mental status examination. So we're going to take a 5-minute break. But before we take the break, I'm going to discuss about the course now. And after that, we will take a 5-minute break and we will do a role play just on a like a simple case. And if any of you who are already you're preparing for the exam and you want to do a role play, that will be really good. So we will see how you're doing. Okay, so let's talk about the course in between, and then we can move forward again. So the the course is a 5 months course. Let me just share you a few things so that it's easier for you to understand. And you can ask questions now about anything that you want to know about the course. And you can also unmute yourself and ask questions if you like. So, First Aid AMC clinical course, it's a 5 months course. Now, you might think that it is a long course and you want to appear the exam in the shortest possible time. Unfortunately, there is no more exam date available for this year. If you haven't got the placement, then you are not going to go for exam this year anyway. So your exam is going to be next year. So in that sense, you will have time to finish. And ideally, you should keep at least 6 to 8 months to prepare for AMC clinical. It has, like, definitely it is not a cheap exam, and the passing rate is not the highest. So in that sense, preparing for this exam in a way that you are confident enough is really important. And the confidence comes with a lot of role plays. And when we will assess you during the course, we will be able to give you an idea that you are well prepared for the exam or not. Then go for the exam. So if someone wants to finish the course within 1 or 2 months, there is also something that we offer. So when you pay full amount, you will get all the recorded classes of our running batch. So the batch just ending now, that batch recordings will be provided to all of you if you want to finish the classes within a few months. That's totally up to you if you want. And once you make the full payment, it will be given to you immediately. At the moment, we are adding notes and videos in your portal, and already we have done a lot. So if anyone wants to just start going through the recorded classes, going through our notes, this is the right time to do that. And in that way, you will be very much well oriented with the classes. You will know what you are supposed to read, and that will become easier and easier. So rather than wasting the time, I would definitely say if you like our classes and if you are sure that yes, you want to join, just start the process straight away rather than waiting anymore. Because you're just wasting your time by waiting. And you need to pass this clinical exam anyway. So the only alternative for clinical exam is WBA, which is not very easy to get, and it takes a longer time to do it. So clinical exam is must because you need general registration, and without clinical exam or WBA, you can't get general registration in Australia. So you have to do it, unfortunately, but in a fortunate way, it is easy to be done if you actually follow what we are doing. Because a lot of people doing that and they are passing the exam in a very brilliant way. You might think that, well, I don't know how to talk very nicely in English, or my accent is not very good. Doesn't matter. I have seen hundreds of past candidates whose accent is not really like really good, but they pass the exam because their approach is good. They know what they're doing, and they know the important things that they shouldn't miss, and they pass the exam in the first attempt. Can you imagine? So your accent doesn't matter as long as someone or your role player is able to understand you. That is more than enough. So the way of talking, your way of conversation will get better with a lot of role play. You might be shy at the moment to speak in English, but once you start the course, once you start doing role play with us, your shyness or your feeling will not be same. You will get better each month. Okay, but definitely you need to work on that. There is nothing easy in this case. If you work, you can overcome any hurdle that you are scared of. Okay, the course is starting from 11th of August. Today is the trial class. The free 2-week session also will start from 11th of August. So the schedule of this 2-week session will be provided in the Facebook group. So keep an eye and join those sessions if you like. And remember, those free sessions are part of the course. So we don't redo those classes. And you will get an idea how exactly the course classes will look like. So anyone can take just a single class and you can like it. But if you like their 2-week sessions, there is nothing hide and seek in there. So only way to know about a course is actually like this. So get few classes with them and then find out that if you like it or not. Now, the course inclusion, the course is designed in a way so that you get everything, which means you get a theory knowledge and you will also get role play. We'll be doing a full theory based on cluster-wise approach, which will cover everything that can come in exam. And we try to bring a number of cages into a small number of classes. We do role play of the cages that's important for your exam. And also in your portal, you will get recent 4-year sample cages discussion. That means all the role play sessions we have taken in the last 4 years will be given to your portal. And also we have notes from 2018. So we have a collection of like a lot.
आपका लेकर आओ दो
To go through all of them, but at least try to go through the last 1 or 2 years classes. We have 1 to 2 role play
लेना था मेरी
and we have 2 theory class every week.
मिक्स பண்ணா சார்
Most of the week you get 3 classes, so 2 theory session and 1 role play, and some week you can get four. You will also get video recording of all our role play sessions covering the last 3 years, which is currently we have 160 role play videos, which contains at least more than 300 cases covering anything that can appear in the last 3 years. Physical examination is a very important thing for AMC clinical. Many candidates, they just fail the exam because of physical examination. So we keep 1 month to finish physical examination. And our physical examination note is the best among any course that you can ever appear. We also give you online mock exams. We try to take it every 6 weeks, but it definitely based on the interested candidate and how you are doing. We also take classes on communication and patient-oriented approach. You will get the notes and other materials until you pass the exam. So the notes will be accessible anytime, but the recording of the classes will be there for 10 months after we start your course. We also take extensive discussion on job hunting, career pathways, making a CV, RMO campaign, after registration and everything. Sometimes we also take a mentor discussion to help the candidate with their course issues, registration and job related questions. You can also get CPD hours. Like if you are a member of RACGP ACRAM, you can also claim like sometimes even 150 points by adding all our classes in these 5 months. You would also get a course completion certificate, which can be used as a bridging course. If you, as I said, if you don't have 5 months time before your exam, you can finish the course within 1 to 2 months by going through our previous batch recording. The cost is $899 plus 10% admin fee. You will be eligible to get 2 installation, one initially and another half in 2 months' time, only if you join at the beginning of a course. The duration is 5 months. Class days are mainly 3 days, but sometimes 4. We take classes on Wednesday, Thursday, and Sunday from 7:30 to 9:30. And all our teachers are working in Australia for a long time. No one is taking classes who is not a doctor in Australia. And remember one thing that there are courses who take, even some courses cost you $8,000 or $10,000, and it is the same, or even like I would say that the mentors on their course are less experienced, and also they don't have a good way of like taking the course, but it's still you'll be paying $8,000 or $10,000 for that course, and it might not be even 1 month. So we try our best to make sure that IMGs who are already struggling in their country, they can pass this exam in an affordable way, but in a one of the most professional way. And the guidelines that we use in the notes and everything, they are all up to date because we are working in here. We know what has been changed and what are the updated guidelines. So if there is something change in the guideline, we also change it in your notes. So the notes and everything that we discuss, these are updated, these are reference based. So the course is not just going to help you to pass the exam, but this course is, is going to be your core knowledge once you start working in Australia. We we learn a lot of times from our students that their emergency department or medicine department, the initial cages were similar like how we discussed, and they got very good good recommendations and they got very good remarks from their supervisor that they're doing really good. So the courses, when we take a course, we make sure that you are ready to start becoming a doctor in Australia because that's why you're reading, right? So the course is going to help you in that regard so that you can start being a doctor in here, but you become confident to do so. Okay? Now, if you want to enroll the course, you can either contact me by sending a message in my messenger, or you can send an email to firstaidamc4536@outlook.com. This is our website, firstaidamc.com. So in the website, you will be able to see anything that we discussed. So if we go to so this is our website. So in the website, you can also go through our clinical course and other courses. So that's also one of the other things that you can do. Okay, so that's basically about the course. Do you guys have any questions? So the course is going to be started from 11th of August. Okay, so that is the proper course. So once 11th August course starts, the 2 weeks will be free for everyone, and after that, we'll be just going with the flow. And Dr. Ahmed, you can always, because you get all the notes until you pass the exam, so your subscription is already extended, but you can always extend your video recording if you want after 10 months. Dr. Lee, we don't, because there is no way we can update anyone by sending email to everyone, because our course runs just twice in a year, and there is a lot of students who appear this course. So we can't send email or messages for every classes. So the update of the classes will be on Facebook. That's fine, Dr. Delia. If you are unable to attend a class, the recording will be given. So all the classes that we take on a live session, we also give the recording sessions on the portal, ideally within 1 to 2 days after the class. How many months the course will be completed? 5 months. So most probably it will be finished at the end of this year, which is December. Okay, very good. So that's fine. Let's not take any break. So we can do a role play, and then we can allow you to ask more questions, and then we will be able to finish the class for tonight. Is it mandatory to have booked the exam? No, it is not mandatory to book the exam to join the class. Sometimes what we ask you to show us the exam placement if you want to join the running batch. Because we normally don't recommend anyone to join the running batch, which is about to finish in few weeks. Okay, so that's why if someone just want to join the running batch, even they know that it is ending, then we ask them, do you have an exam date? Because what's the why do you want to join a course which is almost at the end? Because that doesn't make sense to me. But otherwise, you don't need to give us any exam date to join. Yes, in every class, we try to do the role plays. So you get 10 months of video recordings from start of the course. Okay. All right, guys. So let's see if someone wants to do a role play. Anyone interested?
வண்டியில தேஞ்சிட்டு போல ஒரு கொஞ்சம் அடியில தேஞ்சிட்டு மாசம் அடிக்குது. போடும் மூடில போடும். போடும் இல்லையே.
Dr. Sharmista,
ம்.
you are interested, you can unmute yourself.
Hello, sir. Hello.
I can't hear you.
Hello, sir. Can you hear me?
போனா
Sir, can you hear me?
Mm, Are you guys able to hear Dr. Sharmista? Yes? Okay, why I can't? Okay, let's see. Dr. Sharmista, can you say something now?
Yes, sir. How are you, sir? Can you hear me, sir?
I can't hear you still now. Just a second, let's see what's going on.
చాలా டைரி கொஞ்சம் கஷ்டம்தான்.
Hello?
Yes. Hello, sir.
Dr. Sharmista, can you say something now?
Hi. This is Dr.
No, it's still
Shomishta.
not hearing. Okay, don't know what's happening. All right,
Okay.
let's not do that then. Can anyone else try to talk? Let's see if I can hear them. Okay, so it must be something going on in my end. All right, so in that case, that's all good. We don't need to do the role play today. I'll see what's the problem with my microphone. So as you can understand, guys, that this is going to be one of our like session that we do the mental status examination. In mental status examination, this is the basic that you normally need to go through. There is nothing much that we are going to discuss for today. This is just the start. We start slowly and then eventually we go more and more deeper. All right. So after we have finished the mental status examination, what we are going to do is we are going to do a role play on all the MSc cases that comes in exam. And with that MSc exam role play cases, you will get an idea that how to do role plays and everything. Okay, so please try to go through this MSc presentation, the aseptic J3R. And on 11th August, we will be doing role play on most of the important exam cases that mainly focus on MSc. The record of this session will be provided on our Facebook. Okay, so any questions for tonight, guys? Online is the go at the moment. So I would not recommend face-to-face anymore. Online is better, Dr. Arthi. And the slides, I don't know what's your name. Your name is showing as Samsung, but the slides are only given to our course student. So if you join the course, then on the portal, you will be able to see those slides or the course notes. The Facebook page link. Good question. Let's give it to you. So if you write first aid AMC clinical in the Facebook, you should be able to get that. Otherwise, you can use this link. All right. Thanks everyone for joining the session. I hope you enjoyed the session. And sorry I couldn't show you a role play today. Don't know why I can't hear some of you, but I'll see what can be done before we do the role play class. Okay. Thanks everyone. Have a good night. Take care. Bye.